Hello and welcome to CCRN Review, Behavioral Psychosocial Part 2. In this section, we're going to talk a little bit about some of those topics we haven't gotten to yet, including violent patients. I want to make sure that you're approaching this patient in the correct way so that you don't get hurt. Unfortunately, too many nurses are getting hurt in the line of duty as a result of trying to be caring and helping our violent patients. For one reason or another, maybe the patient has had some kind of a stroke, or maybe the patient is under the influence of alcohol or other drugs, etc. The patient becomes violent and may very well hurt you or someone else. So we want to approach that patient with a show of force, if possible. If you approach the patient individually, it is possible that you may get injured. If there's a few of you that approach the patient, now one of you may get injured too, but in a lot of cases that patient's going to try and take the easy way out rather than trying to go through the bunch of you. Confiscate harmful objects, so we don't want the patient using some kind of harmful object to hurt themselves or others. Restrain is necessary. Designate a patient liaison, so somebody who maybe is able to get through to the patient. Oftentimes, even though the patient is violent and acting out, one of the caregivers will be able to kind of make a connection with that patient, and that person should continue to work with the patient if at all possible. Speak in simple and direct sentences. This is one thing that we want to do with all of our patients who have a behavioral problem, and really is a good idea to use with any of our patients. Remember that your patients are in an unusual atmosphere. They're got a lot of things going on. They may be very concerned about their health, etc. So we want to be careful about how we're speaking, and if we're speaking with a lot of medical jargon and things like that, the patient may start to become more agitated, thinking that we're trying to hide something from them. Observe them for suicidal and homicidal thoughts. Many of the medications that we give to our patients who have behavioral disorders can end up causing extrapyramidal side effects. These include dystonia and tremor. Okay, so dystonia. We have that rigidity, trembling of the head and of the extremities, reduced arm swinging when they move, so they look very rigid when they're walking, shuffling gait, taking short steps. We may also see some anxiety, depression, paranoia, slurred speech. Oftentimes, though, the vital signs are completely normal. Some common medications that can cause extrapyramidal side effects include these listed here. So you see how many of our patients are taking these medications either in the hospital or at home, and those are patients who may be having extrapyramidal side effects. One other thing to know about this is that these side effects don't necessarily have to happen right away. So we often would assume that, maybe the patient takes a narcotic and right away they feel nauseated, okay? Or the patient takes penicillin and within a couple doses they have a rash. So not necessarily with some of our behavioral type of medications. With these medications, a patient may be taking them even for a period of months before they start to develop extrapyramidal side effects. So we want to be careful and watch for that, even though the patient may have been on this medication even for an extended period of time. The treatment is going to be, I want to give Benadryl. Inderal may be used for some of the musculoskeletal effects. And cogentin. We want to let the patient know that this is usually completely reversible as soon as we take the patient off the medication. Now remember again, the patient is on the medication for a reason. They are on this medication in order to be able to treat some kind of behavioral problem. And so if we take the medication away, the patient might not only have that problem again, but may have it amplified since we are changing the chemistry in the brain. So that's one thing to keep in mind when we're dealing with all of these things. We're dealing with brain chemistry. Remember, we're dealing with those those junctions where we're having those neurotransmitters moving across. And if we start to take away the medication, we may go into a situation where we have those neurotransmitters kind of going crazy, and the patient may have all sorts of additional effects. Another side effect of these medications is called neuroleptic malignant syndrome. And this is a situation where the patient will develop hyperthermia with severe muscular rigidity. And that's what really causes the hyperthermia, is all this muscle rigidity is causing a lot of heat, and we're not able to get rid of that. It can occur within days or months of initiating this antipsychotic medication. What we want to do with this is we want to, first of all, identify it. So we're going to identify it by that increase in the patient's body temperature, along with seeing muscular rigidity. We may also see some instability of the autonomic system, where we're having an increase in blood pressure, a decrease in blood pressure, our heart rate's all over the place, changes in level of consciousness, etc. So we stabilize the blood pressure, try to normalize the temperature, and we may actually have to use cooling in order to do so. Correct the hypoxia if there is any. And then Dantrium is the medication that actually is going to treat the problem here. So we want to give that medication, and in the meantime stabilize the blood pressure, normalize the temperature, so that we're not getting additional complications as a result of having neuroleptic malignant syndrome. Test taking tip time. We have a couple other ones here. Chunking your studying. What we found is that by chunking studying, in other words, using frequent short bursts, it's more effective than long study sessions. Now, many of us in college, we had our cram sessions, and maybe we got together with some friends the night before an exam, and we studied for hours, going over all the material before the exam the next day. Or we might have done this individually, by ourselves at home. We just, kind of lock ourselves in a room and we cram all night long. How many people have done an all-nighter? Really. A lot of us have tried those all-nighters. Cramming's not going to work for this test, because this is not a test just of your memorization. So you can go through all of this information and try to memorize as much as possible, and it's not going to work. You need to understand the concepts. If you understand the concepts, then you can apply them in different situations. This is the same thing that happened as you went through your nursing career. When you started out as a new nurse, a novice, you started out with pieces of information that you had memorized, and you tried to apply that, and in many situations you were probably wrong, and you needed to have a more experienced nurse help you to be able to understand how to use that information. But as time went on, you got more experience, and now you're able to apply those concepts in different ways. So going back now and taking those concepts that we're learning here and starting to apply them a little bit at a time is going to help you to be able to remember it. So when we're doing this frequent short bursts of studying, let me give you some examples. Maybe you spend 15 minutes in the morning, 15 minutes at night every day doing your studying. That doesn't sound like a whole lot of time. 15 minutes in the morning, 15 minutes at night, and you want to go back over things that you've already learned. So not just continually moving through new information, but you want to go back and review too. So maybe your nighttime one is the review, or maybe the morning one is the review, but one of those should be reviewing time, and the other one could be moving forward and spending 15 minutes on looking over some other piece of information that you are trying to learn. But think about chunking it, chunking your studying into short bursts that are frequent, rather than having those long study sessions. Suicide is another one of the problems the ACN wants us to know about. This little poem here was written by a patient who had depression and was thinking of suicide, and she wrote this poem which kind of tells it all about somebody who feels that way and feels like suicide might be an option. So there are some things we want to look at with our patients and who are possibly at suicide risk. Their gender. We want to be looking at gender. We want to be looking at their age, their race and ethnic groups. We've had a crisis, really, in our country in the last few years where the rate of suicide among teenagers has increased dramatically. So especially teenage girls, there is a much higher risk of suicide than there has been in previous decades. One age group that we may not consider as being at high risk for suicide, but that is our elderly population. So as people start to age, as they start to lose some of the functional capability that they've had all their life, maybe they're starting to lose some of their memory at the same time, they may start to feel like they're not contributing to society anymore, and that they might start to wonder whether or not they have a part in this world and whether or not suicide might be a good option. That same age group, the elderly population, is also a population that we have to be careful looking for the possibility that they could be having problems with alcohol and drugs. Oftentimes, I think we think about alcohol and drug problems as being problems of the youth, but that's not necessarily true. We have lots of our elderly population that are having difficulty managing alcohol and drugs. And again, probably for the same reason. They're starting to lose some of that functional capacity. Oftentimes they're retired, so they don't have that work piece anymore that's fulfilling them. And so then they start thinking possibly about suicide. Is there a family history? Seasonal, the seasonal depression that occurs, especially in the colder climates, where we may not have as much sun and people aren't out in the sun as much as they are other times of the year. Symptoms, feelings of worthlessness, restlessness, and agitation, GI complaints, fatigue, insomnia. So these are all symptoms. Now, when you take a look at this list of symptoms, quite a few of them are things that happen just to people all the time, so not a sign of that you're going to commit suicide, but, maybe a sign that you've worked too many days in a row, you had too much fast food, or, whatever the case may be. But we have to be careful when we're looking at this, because sometimes we will some of these symptoms we may be very likely to dismiss and say, a little restlessness, a little GI complaint, insomnia, it's just because, of whatever. But those could be underlying symptoms of the sleeplessness that's caused by the depression and the feelings of worthlessness. An actual attempt that was unsuccessful. So a big red flag here. If the person has already attempted or they have a plan for attempting suicide, that's a much higher risk person than someone who doesn't. Chronic illness with little help of improvement. Now, remember I mentioned before that the elderly population is at a high risk for suicide as well. And this is one of the reasons, chronic illness with little hope of improvement. The risk of suicide in patients who have heart failure, newly diagnosed with acute heart failure, and their risk of suicide goes up to about 30%. Now, after they start being treated and their symptoms start to get a little bit better, then it goes back down to what everybody, just their age appropriate level of suicide. But 30%, it jumps up dramatically during that acute phase because the patient now realizes they have a chronic illness and they don't see it getting better, and they don't see that they're able to return to their previous level of action of work. So our interventions are: evaluate the problem with the patient, involve the family and friends, contract for safety. Again, this is just magical. For some reason, they signed that paper and now suddenly they can't hurt themselves because they have signed the paper. So this is something that we want to do. Now, even though we're not going to have the patient sign a paper saying, hey, I'm going to be safe while I'm in the hospital, certainly that's something that you can contract, at least verbally, with the patient and say, while I'm here with you today, I expect that you will be safe and you'll act in a safe way. And I expect that you will not hurt yourself. Now, can you agree to that? And that's oftentimes a good way to find out where your patient is at. If your patient says, no, I can't agree to that, well, so what's going on? Those at highest risk are those with a mood disorder, substance abuse, previous attempts, previous self-harm, and plans of action. Sometimes our patients who are trying to commit suicide, or maybe somebody who's just kind of inexperienced with alcohol and drugs or whatever, will end up having some ingested poisoning, and we may have to work on that piece as well. So with any ingested poisoning, maybe it was accidental and somebody accidentally ate something that had a poison in it or on it or whatever the case may be. We want to, first of all, go to the gastric lavage with activated charcoal. So those are some of the pieces that we would use right away. This illustration here is showing a gastric lavage setup. But we go to the gastric lavage and then we'd put in some activated charcoal. The activated charcoal actually will absorb many of the poisons. And so that's why we give it, is to help absorb. Now, the other thing that activated charcoal will do is activated charcoal oftentimes will give your patient, it'll stimulate the GI tract and help to move things through. So that may be helpful as well. Years ago, the first thing we would do is try and get that patient to vomit. So the patient maybe overdosed, they took too many pills, maybe in a suicide attempt, or maybe just, for whatever reason, they took the wrong medication or whatever, but they took too many. And so the first thing we would go to is trying to get the patient to vomit. And for years, what we used was Ipecac. Now, Ipecac will cause vomiting, but it takes about 20 minutes to cause vomiting. So in 20 minutes, most of that medication has already been absorbed. And so now we're having the patient vomit, and they could be maybe unconscious because of the medication that they've just absorbed. So we want to be very careful with that, with using emesis. There are specific antidotes that we may find helpful, including Narcan or atropine, methylene blue, and acetylcysteine. So those are all some good antidotes that may be helpful in certain kinds of overdoses in our patients. Supportive therapy, we want to support their cardiovascular system, their pulmonary system, depending upon what this specific overdose is going to affect. So say, for example, your patient may be overdosed on calcium channel blockers. So we want to be careful that we are assessing their cardiovascular system. And, calcium channel blockers actually are a very common medication to overdose on in our elderly population. They're often taking these medications at high doses because they're sustained release medications. And maybe they take it in the morning, and then they, about 10 o'clock in the morning, say, geez, I don't remember if I took my medication. And then they take it again, and then afternoon comes, geez, I don't remember if I took my medication. They take it again. And so now you can see how an overdose would occur just because they're not remembering whether or not they took their medication. In situations like a narcotic overdose, we have to be very concerned about our pulmonary system because the big concern is that patient will stop breathing. We may have to treat seizures. We may have to be concerned about supporting our patient if they start to develop an increase in intracranial pressure as a result of this overdose or this ingestion that they've had. So let's talk about some specific types of drug problems or overdoses that might occur in our patients. Alcohol is one of the few medications, drugs, that a patient can withdraw from that could actually be deadly. So the patient with DTs can actually end up dying as a result of DTs. So very concerned about the withdrawal in this patient. The patient is withdrawing from other medications, maybe even like heroin. They'll feel like they're going to die, but they're not going to die from the withdrawal. So with DTs, we want to treat them appropriately, giving some Ativan or Librium and watch the patient very carefully for signs of withdrawal so that we can get them through that initial period of withdrawal. This diagram here is illustrating the withdrawal syndrome, alcohol withdrawal syndrome. See, at the very beginning there is the high risk for seizures, and then we move into all this tremors, irritability, insomnia, confusion, kind of peaks here with about day 3 to maybe day 8. I actually have hallucinations occurring here, maybe around day 2 to day 5. So we've got a lot of stuff going on there. And out to about 14 days, we can still be seeing signs of alcohol withdrawal. So our signs and symptoms include anxiety, agitation, tremors, elevated vital signs, tachycardia, hypertension, maybe even some increase in the patient's body temperature. Cocaine, on the other hand, is a cardiac stimulant. So we can anticipate seeing some stimulation of the heart. Unfortunately, what can happen is even with just one use of cocaine, that patient can develop a cardiomyopathy as a result of. So we want to be very careful. We're watching the cardiovascular system. But here you can see all of the different effects that cocaine would have. And so since it's a stimulant, we'd expect to see an increase in temperature, increase in blood pressure, heart rate. But there is a risk of respiratory arrest, on the other hand. On the muscles, tremors, twitching, we can have loss of balance. We can have a dilation of the pupils. Our treatment's going to be symptomatic. Okay, and you can see some of the long-term effects here as a result of whatever way that they are getting the cocaine in the first place. All right, another test-taking tip here. You will retain more information by repeatedly reviewing concepts, and flashcards can help you to frequently review for the exam. There's a number of ways you can do this. One way is to make your own flashcards. So certainly you can do that. As you're going through, look for those concepts that are kind of troubling and maybe highlight them in your workbook. Then go back and make flashcards out of those concepts. So make a question, give yourself the answer on the back of the flashcard, and work it through. There are also flashcards available on the internet, so you can do flashcards that way. Quizlet has flashcards. So Quizlet.com, that's a organization that's on the internet that has a bunch of like pre-made type of flashcards. So you could use something like that, and you can make your own. So you could just go in and sign up for an account, free account, and you can make your own flashcards, and you can go back and you can review your flashcards again. So that might be another possibility as well. Well, thank you for joining me for CCRN Review, the behavioral psychosocial aspects. Let's move on and review the questions from the beginning of the chapter before you move on to our next section, which is to endocrine. Thanks for joining me. Let's move on to the next section.